Hi, everybody. Thanks for joining us. We have quite a few people trickling in, and I'm expecting more people to be trickling in over the next couple of minutes. This is obviously only 30 minutes, so I'm going to kick off pretty swiftly. But before we start the conversation and I'll have the panel members introduce themselves, I'd really love you in the audience to put in the chat what are you most worried about for AVTs. And some questions, some of your answers will pop up on screen. So we have people behind the scenes helping us. And this will really give us a feel of where people are at and what they're thinking about. And while you're typing those answers, I want to explain why we decided to do this. So you may have seen some research that came out that included Keith and Youssof with their researcher hats on, as well as some other academics, that found 3 out of 4 NHS trusts are not adhering to the mandated standard for managing clinical risks of digital health products. And you may have also seen in national policy guidance that we have a particular digital health product, AVTs or AI Scribes, which should be coming at pace. So they're already in healthcare, but they should be coming faster. And when you pair those two facts together, that for me, that's something that I would like to address, and everybody else in this would presumably like to address. So we got together and we produced some guidance on the standard that applies to healthcare organizations, DCB 160, but also AI Scribes. And we'll talk a bit more about that guidance and share it during the course of this webinar. But this conversation is just to kick us off of what is DCB and what AI Scribes and how do we navigate this space. And it's part of a much bigger conversation that we'll be having at Hale House on the 12th of May. So Zainab behind the scenes, will put a link in the chat of this event that we're holding. And so it's going to be all focused on AVTs across a couple of hours. There'll be a keynote from Professor Alistair Denniston, who you may know as the chair of the MHRA National Commission on Regulating Healthcare AI. There'll be a presentation on monitoring AI Scribes in real time. I will give a short presentation on a public dialogue I ran last month on AI Scribes. And there'll also be a panel on local perspectives and national perspectives of keeping AI Scribes safe. And I'm really excited for this event. And I hope I see you there. There's already been quite a few signups for it, as we sent out some private links elsewhere in the NHS. So Zainab, if she hasn't already, will put that in the chat. The post-deployment monitoring. Yeah, great one. I'm sure that's going to come up. So let's kick off this conversation. We don't have much time. So first, I'm going to ask the 3 panelists to introduce themselves. I'm Robin Carpenter from Luton Street, by the way, but I don't matter. It's these 3 that do. So in order of Keith, Youssof, and Haris, can you introduce who you are?
Yeah. So, hi, my name's Keith Grimes. I worked as a GP in the past. I'm the founder of Curistica, an innovation consultancy that does clinical safety and governance work for either people building or deploying technologies such as artificial intelligence.
Thanks, Keith. Youssof.
Hi, everyone. I'm Youssof Oskrochi. I'm a public health clinician, CSO and DPO, and I work with Keith as the head of safety at Curistica as well.
Fantastic. Thanks. And last but not least, Haris.
Thanks, Robin. Hi, everyone. I'm Haris Shuaib. By background, I'm a consultant medical physicist at Guy's and Tommy's, founder and CEO of Newton's Tree.
Fantastic. Thanks, Haris. I'm actually going to start with a question for you, Haris. Can you get us all up to speed and tell us what an AVT is?
Yeah, of course. I feel like I'd be very surprised if lots of people in the audience still know what it was. But for those that don't, AVT or Ambient Voice Technology is known by many names. You might hear it called an AI scribe or ambient listening technology. It fundamentally is a piece of software that listens to a conversation between a doctor and a patient and automatically writes the clinical note for them. That is what it is in its simplest form. You can think of it as a digital assistant that types up what happened during your appointment. What's interesting today, though, is a lot of the ambient voice technologies have become more richer in functionality than that, and actually help with other tasks associated with the appointment, like writing up the letter that gets sent home, or follow-up actions like referrals or orders that need to happen. But that, in essence, is what an ambient voice technology is.
So really just at the start of this journey. And I should also highlight right now, so I'm going to be asking the panel members a couple of questions to make sure we cover the ground. And then I'm going to cover some questions that were submitted for this webinar. And then after that, we'll move on to the Q&A within the Q&A function of this webinar. So if you want to submit questions as we're talking, then we'll try to get to as many as we can at the end. So thanks for that summary of what an AVT is, Haris, for those of us us the one to get up to speed. And I'm going to move on to you, Keith. I want you to pretend that I'm a 5-year-old, and I want to explain to me, as a 5-year-old, of what the DCP standards are. Best of luck.
All right. Okay. Well, at its simplest, if you go and visit a doctor or a nurse, you would expect the things that they do for you to be safe. Clinical safety is about showing that the technology, the computers and the software they use are safe. The clinical safety process is something that people do beforehand, where they look at what a program will do or a bit of technology will do and who it will do it to and where it will do it. And it's a structured approach of saying, well, if we've built this thing and it's going to do these things, what could go wrong? And if something went wrong, what kind of harm or hurt could it cause? It's a structured process where you go through it. You identify what could go wrong, what you do to stop it going wrong, and how do you prove that those things that you do to stop it going wrong are in place. You wrap that all up with a letter that explains, or a document that explains that you've done all this, and you say, yes, it's safe to use. But there's a second part, because when you take that software and you put it into a hospital or a practice or something like that, the manufacturer or the person who built it is expecting you to do certain things to keep it safe. So the second part of it is that people look through it in the same way. Can we do these things? Is there anything different about how we're going to use it that we need to control for, make safe, provide the evidence for this? And the final bit is that you don't just do this once because you're using it, you're going to keep an eye on it. You're going to keep an eye on it. And if anything goes wrong, you can fix it if you want to add in new features. So that is probably too 5-year-old for this audience, but it's at its simplest. And that's exactly what it is.
Cool. Now we have that foundation. Can you build upon that? I've suddenly aged by about 15, 20 years. And tell me what the two DCP standards that people tend to think about and the documents that you might find underneath that, just very briefly.
Yeah, sure. So DCB standard came about 2012. It's legally required in the Health and Social Care Act, Section 250 from 2012 in England, and it's considered best practice in the other home nations. There are two parts, 0129, which is the manufacturer side, and 0160, which is the deploying organization side. It applies to any health information technology or digital health technology that can be used in a healthcare setting or adult social care settings. And the components will be a clinical risk management system and plan. This is how you undertake the process and how you monitor the performance and safety of the product when it's out in the live. A hazard log, which is a breakdown in a structured way of what could go wrong and what you're doing to stop it going wrong. A clinical safety case report, which is your argument, and then a safety issue or safety incident management log, tracking what happens. And the 0160 side is very similar to that.
Fantastic. And the 0160 side is obviously what we're focused on today, and that's about the healthcare organization.
Absolutely.
Fantastic. Thank you, Keith. And over to you, Youssof. So obviously there is this standard. We know that it isn't followed to its fullest extent in many cases. And we have often found that there are misconceptions about DCP standards. So I would hope that you would be happy to highlight some of those misconceptions and maybe put them to rights.
Yeah, of course, happy to, Robin. So one of the things we get, we all understand that the compliance work, awareness of the standards is limited anyway as it is, and even fewer people actually can manage to do the process as well. And I think a lot of the time it's just possibly overcomplicating what actually needs to be done. And one of the things is people say, oh, we don't have a CSO, or that they think the CSO has to be directly employed in-house by you. And that's just not true. Same way that a DPO can be, can cover multiple different institutions or practices. All you need to have is a named CSO that can review, verify the clinical safety case and the hazard log and authorize it. And just to be clear, the CSO doesn't need to do the work. They have to review and authorize the work. Okay, so that's a really key thing that trips a lot of people up. The next one we get a lot, this is the more recent development, is especially with context of AVTs, is, and we've had this at Curistica, is we have clients saying, oh, but the AVT we're going to use is on the NHS England self-certified supply registry, so we can just use it without anything, right? That's not quite true. In fact, it's not true at all. The AVT registry only confirms that an organization has told NHS England that the documentation that NHS England have asked for is there. That's it. There is no checking of that documentation. There's no quality control. There's no due diligence. Everything is still on the organization. The response is still with the organization to check, for example, that the data protection aspects are appropriate, that the cybersecurity certificates are in place, and they still have to do the DCB 0160, for example. The next question we get is, okay, but our neighboring trust or neighboring practice has done DCB 0160. Can we just use theirs? And again, the answer is no. The reason is that the thing about 0160 is it is locally specific. It is based on your internal processes and governance structures. And for example, if in the practice next door they have a monthly risk assurance meeting where they feed complaints in, and you have one twice weekly, that automatically doesn't map across. Or if the escalation pathways are different, that has to be reflected in the DCB or 160 safety case, because that materially impacts how the risks are identified, mitigated, the whole works. So let's say you've done all that. Let's say you've got 0160. The next one is, oh, we've done 0160. It's done. That's it. Let's file it away and forget about it forever. Again, and we'll come on to this later on as well. A clinical safety case is not a static instrument. It's a dynamic instrument. And especially in the context of AI technologies, which change over time, they need to be regularly reviewed and assessed. So whenever we do a safety case for an organization, we introduce triggers that would define review periods. And these, for example, are changing functionality, change in safety critical instruments, or literally, it has been 12 months since we looked at this. Again, these are not things that are new to anyone. People, clinicians, practice managers do this normally. It's just applying it with a different nuance to technologies that we traditionally haven't applied this process to.
Fantastic. Thanks, Youssof. I appreciate that. Zainab, I wonder if you could bring up the document on the screen so people can see it, and particularly page 8, which shows some of these misconceptions. So there is a link. I wonder if we can... there we go. Okay, fantastic. So as you'll see, this is it's about 50 pages, this document, and so this covers some of the things that Youssof just covered, common misconception. And as I say, the whole point of this is to help people wrap their heads around and really get to grips with this DCB standard, and particularly applying it for AI Scribes. So it describes what the DCB standard is in more detail than we've covered today, and it also covers what AVTs are, and also gives some hypothetical documents, and also a hypothetical safety incident, which we'll cover in a little bit. And as I should probably also say, then it's free. We're not trying to sell you anything. This is just a thing to try and help. So there should be a link in the chat where you can access the document if you want. Okay, if we take that off the screen, that'd be great. Thank you, Zainab. And so now, Keith, I mentioned that we have this hypothetical AVT that's within the document. Could you tell me a little bit more about this AVT that we use and the development of the clinical safety case around it?
Yeah, sure. So we wanted to be able to talk about how you might manage an incident or an issue. And of course, if you want to do that, you need to have the 0160 for this, which is the safety case and how you'd manage that. So if you need that, you also need an 0129, because an 0160 comes from an 0129. And if you want an 0129, you need a product. It would not maybe be fair to take a live or real product to do so. So we created a synthetic one. We didn't build it, but we've got there's another link that we'll share. So we created a hypothetical one called Cadence, which has all the usual features that you might expect in an ambient voice technology, with maybe an additional one that receptionists might be able to use it. So when you look at the other link that we will share on this, Cadence is the name of this AVT. It's not any of the live ones out there right now. We then created a fully synthetic 0129 with clinical risk management system, plan, simulated hazard work, clinical safety case report, the whole lot, all of which you can see, allowing us to do the same with a simulated fashion on 0160 to get us to the point where we can talk about an incident that happens. But Cadence is an entirely fictitious ambient voice technology.
Thank you. And so I just note that there's a question in the chat as well by Professor Ralph. I wonder if you could elaborate this question. So you've asked, where is the accountability in this system? And I'm going to pull that question in a bit. If you could just give a bit more detail of what specific system or systems you are referring to, and what you mean by accountability. Thank you. And so why that's happening. So I want to now bring this over to you, Haris. So we have obviously this hypothetical safety instance within our document, and it's only one instance. So I'd really love you to elaborate on the clinical risks of an AVT.
Yeah, it's a big topic. I mean, ultimately, with any sort of clinical risk assessment of any health IT system, you want to take into account the entire workflow and what the potential outcomes are. The real challenge with general purpose technologies like ambient voice technologies is that the patient pathways that they interact with or influence are obviously all of them, right? Because it's not specific to any one disease or patient cohort. And also the nature of the technology is a lot more complex compared to non-AI or deep learning systems. And often the way we look at the causal factors around some of the risks related to AVT technologies, there's usually three large domains that influence any harm that might arise from the use of ambient voice technology. One is the quality of data going into the AI models. And for ambient voice technologies, we know that things like the quality of the audio, and that can be the microphone quality itself, the positioning of the microphone, ambient noise. If you're in a noisy secondary care, emergency department versus, a GP practice, those all influence the performance of the algorithm itself. Then there's the language model performance. A lot of ambient voice technologies come with templates that allow you to constrain the output of the AI technology, and that works to varying degrees. Ambient voice technologies or language models have a tendency to hallucinate, and this is where they create artifacts or outputs that are not rooted in reality or the source data. And then the final component is the human aspect of it. And some people in the chat have highlighted some of those, particularly around automation bias, right? So, running a busy clinic, this technology is supposed to help you be more efficient. There is a tendency, not just with ambient voice technologies, but with all sort of assistive technologies, to over-rely on their functionality. And given the challenges around data quality and hallucination of language models, over-reliance can lead to pretty negative outcomes. If the AVT hallucinates, a reported diagnosis or illness or misses one from the consultation, and the clinician doesn't catch that mistake, that makes it into the medical record. And like I mentioned, some of these ambient voice technologies are now not just updating the record, they're also now taking the next action, like communicating to other healthcare professionals or filling orders or making referrals. Patients are then having their care dictated by these mistakes. And that can lead to misdiagnoses and, in the worst case, mistreatment, either under-treatment or people being treated for things that they don't need to be treated for. And so that's the scope of the challenge that we have when we look at the clinical risks that are potentially produced by AVT technology, fundamentally driven by the nature of the tech itself, how creative it can be, and its broad use across the health system.
So I want to preempt a question which I imagine is going to come, and this is off the cuff, so apologies, Haris, to put you on the spot. But you often hear people saying that our AI product is okay and it's safe because we have human in the loop. So what does automation bias, if you described it as over-reliance, what does that mean for human in the loop?
Yeah, we hear this a lot, and sometimes the human's not in the loop, even when you think it is, right? And I think there's a couple of challenges with human in the loop. One is it's a really convenient get out clause for folks to say like, oh, it's okay, there is a doctor that's going to check this or a nurse is going to check this. And that creates two kinds of problems. One, it puts unfair amount of pressure and liability on that person. That person is expected to sort of mop up the failures of everything that comes before them, right? So if the microphone is faulty, if the language model hallucinates, if it doesn't integrate with the EHR correctly, all of those faults are, suddenly now the job of the doctor to fix or to sweep up. But secondly, even when, and actually especially when everything is actually working really well, you create sort of the perfect scenario for the human in the loop there to check out, basically. There is a very human tendency. We see this happen all the time with, spell checkers, but also even things like self-driving cars. When a system is very competent, when it's 99.9% accurate, we treat it as it's 100% accurate. And that can be some of the most dangerous dynamics. And actually, at Newton 3, we did a study looking at radiology AI solutions across 2 hospitals in the UK. And we were able to measure this effect happening in real time, where radiologists, over a period of 3 months, week by week, were agreeing more and more with the same AI technology than when they first started. And what was interesting is when we looked at the skill mix or the staff mix at the different hospitals and the different staff members, it tended to happen with more junior members of staff, and it tended to happen out of hours, which is when you have other distractions and time pressure, because you're often covering a much broader portfolio of work than during the day. And so when we think about human in the loop, we have to think about these sort of socio-technical factors, which is what is the human doing? Like what part of the day is it? What kind of support do they have? What kind of training have they had? But otherwise, it's a bit of a delusion.
Thank you. Okay, I'm going to move us on. I could happily talk about this all day, but I won't. So within this the document that we created, we had this hypothetical safety incident, a fatal hypothetical safety incident that involved a scribe that over-focused on anxiety, which meant that it missed the sign of a heart attack. And then this was missed by the humans in the loop because of time pressures, but also a handover. And so I want to put it to all of you, you take your turns to answer and push back on each other. If this was to happen in real life, what would be essential for managing this or any other safety incident that happens in practice? So you have your DCP documentation ready, you've done your risk mitigations, but a real safety incident comes up. How do we deal with this? Yeah, who wants to go first?
Maybe I'll come in first, and everyone will have access to the whole stack, and there's plenty reading, don't worry. But in this case, you're sort of talking about this incident. And I mean, the first thing to say is that this is an AVT being used in an emergency department. And that, first of all, shows that an emergency department is very different to a general practice consultation room. It's noisy, people move from place to place. And the stack of information that we're giving you shows you that a manufacturer has done the right thing, but the organization notices it's going to be used in a different way, have made some changes, and so on. Yet still an incident happens here. I think the important thing when an incident does happen is, like any incident, whether it's technology, drugs, whatever it is, that you have a process in place and you just ensure that everyone is made safe. I think in this situation, the important thing was that a clinical risk management plan was in place and people knew it. It wasn't just sitting on the side. And that they enacted it as well. So when you look at the incident, and the incident's been written up, obviously, like an exam question type answer, it calls out exactly what things have happened here. The clinical risk management plan had different grades of incidents. So when something happened, they were watching out for it. They had a reporting mechanism that triggered an immediate escalation, a decision to pause the use of this as well. You would have to process and manage the human harm and everything as well, but the technology had its own path as well. So I think that's the first thing to say, is that you have a clinical risk management plan that is worth the paper it's written on, that people know about, can trigger it, and that you follow it. That it's done and sits somewhere in a dusty folder is no help at all.
I often think about that across the regulatory space, so in data protection as well, how much easier and safer you make your lives by doing your thinking well before an event happens than you have. You can fight fires. Youssof or Haris, do you have anything to add to that?
Yeah, Haris, I hope you don't mind going first. So I think for me, a response to an incident. Now, historically, when something happened with a drug or a system, that is a static piece of kit, right? You cannot go back to the manufacturer of penicillin and say, can you change this methyl group attached to the end of this X carbon because it didn't work? You can't do that. But with the DHC, you absolutely can. Right. If there is a incident involving a patient, most of the tech companies we've dealt with are very responsive to feedback. You know, as part of the CRMP, as part of the CRMS, as part of your relationship with someone you're procuring your devices from, you should have a two-way relationship. You should be able to give them feedback. That's not just about incidents, but also from user feedback. So, because you can tailor it now. We've seen it, with some of our clients. Each practice has its own interface. They have their own unique deployment of that particular product. So I think as part of any incident, I would want to involve the manufacturer early, get their insight, because they're going to have access to data that you don't, see how the system responded, semantic matching, whatever it is, to say, actually, can we limit this in future? And going back to what happens at the end, if something unfortunate happens, you have a duty of candor to the patient, to their family, to say this is what happened. You also have a responsibility as an organization to learn from it and put in place mitigation to stop it happening again. So as Keith said, the minimum would be a review of the hazard log and updating because now you've got data about the frequency or likelihood of the mistakes to update that. But that information is also useful to everyone else. And just to be clear now, since DTAC 2.0 came out, there is now a mandatory requirement that any patient safety incident is reported via the Learning for Patient Safety events nationally. So you have to submit that so that everyone else can benefit from the unfortunate events that have happened with any sort of technology that there is.
So, Haris, are you happy if I enlist this something you're burning to say? I actually want to take a question from the chat and throw that at you instead. So Karen has said, with a general audit, who is responsible for identifying data drift? Do you want to?
Yeah, good question. Whatever the documentation says, that's the person who's responsible. It's a partly flippant answer, but no, but it is an important one. So whenever I talk about helping health systems and hospitals adopt AI technology, I always talk about the 3 Ps: people, platform, and policy. And Newton Street obviously tries to solve the platform component to it, but an equal part of that trifecta is the people involved, and whether they're the right people and have the right training and capability and authority as well in their organizations. Ultimately, this needs to sit within your broader clinical governance and risk management framework. I'm never a big fan. I mean, in some ways, in some regards, you do have to treat AI differently, but only in the details. I always say that the broad principles need to plug into the rest of the broad principles. And so in an organization, you'll have a corporate risk register and you'll have a risk committee, right? And potentially chaired by your chief medical officer. And the different service leads or quality and risk officers of the different services and departments have then departmental level responsibility that feeds into the corporate risk register and risk management process. And so I would want as much as possible to feed into those processes. What we do find, particularly in hospitals compared to, say, primary care practices, is they've set up governance committees for AI specifically. And at least for an intervening period, they become a venue for reporting, monitoring, and managing things like data drift, because the traditional apparatus, like the Corporate Risk Management Committee, doesn't have the right people, experience, processes to deal with that kind of data. And so that's what I see sometimes today as well.
Fantastic. Okay, so I'm keenly aware of time. We technically have 1 minute left. I don't know if we can run over by 1 minute or two, but I'm going to rapid fire send pre-submitted questions at you and ask for succinct answers. Okay, Youssof, you first. If nobody follows these standards, what's the worst that can happen?
I mean, you've seen the hypothetical situation, but we've had plenty of examples of clinical safety incidents going back decades. So in 2000, there was a Pathline error where, if you're not aware, Pathline was a software used for identifying Down syndrome in pregnancy. So Trisomy 21, there was an error due to an update for the Y2K bug, and that caused 150 women to get incorrect results as a result of their screening. So some women were told they were high risk when some were actually low risk, and vice versa. What happened was 2 people had determinations that were misinformed. So they were told they were high risk, actually low risk. And 4 women had births to Down syndrome babies when the expected should have been 1 because they were told they were low risk. Okay. More recently, we've had component failures in glucose monitoring kits for pregnant women, where when the monitor couldn't communicate with the phone just made up a number. It just made a 1 up, okay? And it just gave that back to the user, so they couldn't really act on it. So one of the issues we have, we've sort of talked about this, is because the governance structures and our monitoring structures are not in place, we can't really see the extent of harm that's actually occurring. And also, a lot of clinicians, doctors, nurses, physios are picking up and fixing these problems as they see it and not really thinking, actually, is there something wrong with the software that's doing this? So actually, I think the problem is much bigger than we think it is, but we're just not seeing it.
Fantastic. Okay, Keith, quick question for you. It's only mandated in England. Is it being adopted elsewhere?
Yeah, actually, interestingly, it is. So I'm from Scotland originally, and I'm delighted to say that there's a lot of interest in best practice use of this up in Scotland right now. And so they'll be using this standard as part of their clinical risk assessment. Similarly, in Northern Ireland, whilst not legally required there's an increasing interest in application of this. So we're seeing clinical safety officers being trained from both. And of course, Wales has been doing this for a wee while now as well. So even though it is not legally required, what we're talking about here is one method of implementing AI and digital health governance. And we already do governance of doctors, drugs, and devices. Why don't we do it for digital health? It's very similar in many regards with some technicalities. We just need to fill the gap. It should be just good practice. That there's a legal mandate to do it, well, as we've seen, it doesn't necessarily mean it's done. This isn't about the paperwork. This is actually doing the necessary work to make sure that the things that we're using with our patients and our staff is safe and doing it on an ongoing basis. That's simply it. So it's varying in different places, but I think we're all coming together, and AI is focusing people's minds.
Fantastic. Thank you, Keith. And sorry, I'm going to do one more question to you, Haris, before I give us a wrap-up question. And this is quite a practical question that I imagine people are really going to have to deal with. What happens if the manufacturer does not share their DCB 0129?
Yeah, it's a very good question. So it depends on where you are in this process or in the process of working with the manufacturer, right? So we try to coach our partners in hospitals as much as possible to bake this into the pre-procurement or the procurement process, right? for most of us who have been sort of on the buying side of technologies inside the health system, that's when you have most of your leverage, right? And also the risk management process starts from project initiation, not from product deployment, right? That's the thing that people get wrong, is when you commit to starting a project, that's when risk management starts. So you should have already had in mind to ask vendors for their DCB. The challenge is when it gets too late. So once you've signed a contract, go live is 2 weeks away, suddenly you've been dropped in it as a safety officer and you have to do your 160 and the vendor either doesn't have or doesn't want to share their 129. There's two scenarios, right? So one is that, can be unpalatable, is you make it a blocker to going live, right? But there's also downsides to that, right? Because often you're deploying a technology to improve care. So delays to rolling out or stopping innovation also causes harm, right? So that's not always the safest thing to do. Absent that, you have to do then a much more comprehensive 160. The advantage of working with a mature 129 is that your job as a deploying organization is more straightforward and much more focused on the outstanding risks or residual risks that you need to mitigate. Without knowing what the residual risks are, you have to take this as a completely unknown product and do sort of a complete ground up analysis. And so it just makes it a much more involved and expensive process from a time perspective. But that's the way you have to proceed without collaboration with the vendor.
I was going to say, importantly, it can be done, but I think what also works is reminding the manufacturer of the law.
Yes. That's a very good point.
Fantastic. Thank you. Okay, so we're going to wrap up. So I asked the audience what were they most worried about with AVTs. We had some really great answers, like post-deployment monitoring, really this point in time in the NHS. Verification and validation, risk based on user environment, confusing and conflicting messages. Yes, I think we can all relate to that as well. But I want a succinct answer from you, Haris, Keith, and Youssof. What are you most worried about when it comes for AVTs? Maybe Haris, then Youssof, then finally Keith.
Yeah, for me, the biggest challenge is investing in the surrounding infrastructure and include sort of people in that as well. It's not always about the tech; it's the context within which it's being deployed in. And my biggest fear is that we're underinvesting in the people and enabling infrastructure.
Thanks, Haris. Youssof, yeah, you're on mute. Youssof,
You're on mute.
Sorry, so someone had to do it. So I think my biggest fear here is, and we touched on this before, is understanding what are we doing with the AVT? So what is the actual benefit of the AVTs? How are we going to use it in practice that is meaningful both for clinicians and patients? You know, it's not just about freed up time, but what is the actual benefit that we're going to take as a system, and where does the delineation with responsibility lie between the clinicians or people using it and the manufacturer as well?
fantastic. Thank you. And finally, you, Keith.
Yeah, I mean, my worry about this is that with AVT, we have very, very rare situation where we've got a technology that makes people feel better when they use it and they actually want to use it. Now, how often can we say that? We've already seen some comments about like the ROI on this and how much time is being saved, and a lot of pressure is being put on AVTs being deployed to save time and increase productivity. If that's the only metric that we do this, then I think my worry is that people will say that AI broadly has failed to deliver on that, because it will deliver some of those things. But the overwhelming evidence that I've seen is that the users of it simply feel better. They feel better about what they're doing. They can attend to their work. They're not so burnt out. They care for their patients more, and the patients feel more cared for. And if we can't implement a technology that does that when we're facing globally historic and punishing levels of burnout, then we have all failed. But equally, it can't all be about that. So my worry is that we over-index on something that AVT can do, but isn't principally good at. And if we do that, it stops us unlocking the rest that Haris had mentioned, which is just, this is the very first part of unlocking a lot of other powerful features too. So yeah, we got to let AI help us become more human and safe, and then we take it from there.
Fantastic. Thank you. And thank you everyone for staying with us as well as we overran by 7 minutes. Obviously, this was just a quick bite-sized conversation. The bigger conversation will be at Hell House on the 12th of May. Thank you for your time, and I hope you have a fantastic day. Cheers.